All right. Okay, Kevin. I mean, you've been on before, but there may be people on here that do not know of you potentially. So could you give like where you were previously, where you are now, and a little background?
Yeah, absolutely. So my name is Kevin McNamara. I'm a doctor of physical therapy, practicing in the Seattle area now. Last year, I completed my sports medicine residency at Johns Hopkins, and then prior to that was going to PT school down in Phoenix, Arizona. So I'm happy to be back. Thanks for having me again, Chris.
Hell yeah. No problem, man. So I asked you to tackle shoulder, and I said prefer. Was I the one that suggested frozen shoulder?
Yeah.
Yeah, I asked you. Okay. So I kind of like put you in a corner, but you accepted it. So do you want to briefly talk about your experience with frozen shoulder, just looking at research or having patients, and then we can dive into the CPG?
So my experience with frozen shoulder, it's been relatively limited, I would say. I've had a decent amount of cases. Certainly not feeling like I'm very adept or have a lot of experience in the area, but a lot of the frozen shoulders that I've seen have been either kind of in the later stages, I would say, where they're in a little bit of a less sort of painful presentation, as opposed to kind of like someone that I saw this week where we actually did seem like we caught things very early. So with regard to frozen shoulder in general, I think it's important to kind of recognize that, first of all, it's kind of a clinical diagnosis of exclusion. A lot of times we kind of come to this diagnosis after ruling a number of things out. And I think that's something that we can kind of talk about a little bit more as we get into the CPG. But really, a lot's kind of unknown about it. We don't really have a good understanding kind of why it develops. Really, we have some ideas on maybe who's a little bit more at risk in terms of risk factors for it, but the underlying pathology is still a bit of a mystery. And with that, we kind of have a difficult time determining what exactly to do from an intervention standpoint. And unfortunately, a lot of it seems like we don't have a great set of tools to kind of address it. So that's something I'll get into a little bit more as we go through the CPG, but that's kind of the broad overview. Clinical diagnosis, one more of exclusion. Generally, when we're talking about risk factors, I kind of organize things in terms of, age, gender, and body part. And when we look at frozen shoulder, we're generally seeing usually kind of middle age. Seems like women may be a little bit more affected. It's not uncommon to see this present with somebody who may have some sort of underlying metabolic syndrome, particularly something like diabetes. Thyroid disorders, another one that we see them presenting with. It's kind of split into categories of primary and secondary, whereas primary frozen shoulder is going to be this sort of very insidious onset, no real mechanism or distinct kind of inciting event. And then the secondary is where we actually see this, where there may have been some sort of insult or trauma to the shoulder. So this could be something, whether it's a post-surgical situation. I've seen people that have had it after, something like a mountain biking accident or something like that, any sort of blow or force to the shoulder. So overall, it's just kind of a black box. So I'll stop rambling there and we'll kind of move on.
That was great. So you chose the CPG, which is great. Do you want to go down kind of through the whole thing, or are there specific kind of points you wanted to highlight in particular? I'm down for either.
Yeah, so I think a good way to kind of start is maybe just kind of looking at kind of the algorithm with regard to kind of establishing maybe where we're at sort of in the process. So the person that's kind of presenting with you, I think it's pretty helpful to kind of look at it through that initial framework, because I think that's going to be something that will ultimately kind of guide treatment and intervention. Maybe talking a little bit more about presentation and diagnosis, and then kind of slowly working our way through into interventions. What do you think?
Sounds perfect.
So I think if we go to the CPG, does everybody get that? I think you sent it out, right, Chris?
Yep.
So shoulder pain with mobility deficits is kind of the way that it's classified through the APTA. And I think, page 10 here, they do a pretty good job kind of producing this algorithm in terms of helping us make the diagnosis. So like we talked about initially, patient's age, they're somewhere kind of in that middle age range. Generally, when we're talking about more of primary adhesive capsulitis, it's going to be kind of that gradual onset. And the biggest thing that we kind of notice is, especially when we're talking about kind of earlier stages, they classically kind of define it as, I believe it's freezing, frozen, and then thawing. And then there's kind of like this earlier period where oftentimes I think this may be a case where we kind of see maybe early adhesive capsulitis more than, or it sees us more than we see it necessarily, because there is kind of this early like 0 to 3 month period where it may present a little bit more, maybe like a cuff tendinopathy or some sort of like biceps tendinopathy. And I think sometimes that may be missed kind of early on, especially when we're dealing with like that female age group, kind of 40 to 65. So that's something to think about there. Have a little bit of a case study that actually kind of speaks to that a little bit later today, that I'll kind of talk to you guys a little bit about. But basically kind of 3 main stages: freezing, frozen, and thawing. In the early kind of freezing phase, this is going to be patients been presenting with, pain in the shoulder for around 3 to 6 months. Usually going to be more pain dominated as opposed to mobility limited, but their stiffness is increasing rather rapidly. And typically what we see in terms of like kind of ruling in, they're going to be very limited in shoulder external rotation or anything where we need sort of that anterior portion of the capsule to have some sort of ligament give or laxity. So especially external rotation and abduction at 0 degrees. So looking at passive and active range of motion is typically going to be presented as kind of stiff and painful in that early freezing phase. Moving into there, 3 to 9 months typically is going to be that frozen. And in this one here, we're going to see more of a kind of restricted as opposed to a painful. They'll still have pain, but it does seem to be like general kind of constraint on the system is going to be more of a lack of motion at the shoulder. And then moving into the last phase, kind of that thawing phase, minimal pain, and then a gradual kind of restoration of range of motion. But I think the important thing to talk about there is the overall prognosis for the time course that this follows seems to be highly variable. And I don't know if we have a good understanding as to when we can provide some sort of information as, range of motion returns at time X. I think that was something that previously had been maybe speculated. They were like, oh, this thing kind of generally follows a natural history within a year or so, things should be back to normal. And I think more recent evidence has maybe called that into question a little bit.
Well, that one of the other papers you sent, it was like the history or the natural history of it is like between 12 to 41 months or something. It's like, that's not a small spectrum of time.
Yeah, it's a pretty large spectrum, right?
Yeah.
And I think that's an important thing, especially as we kind of talked a little bit more about, what do we do from the clinical side of stuff? And I think a lot of it is just kind of, once we suspect this is kind of going on, just kind of setting expectations for the person, giving them an understanding of, we generally see that it follows this kind of, stage-like progression, but just making sure that we're giving them an understanding of what to kind of expect. Because beyond that, I don't know how much control we really have or how great our ability to influence things really is.
That was going to be one of my questions to you or to anyone who's dealt with these type of patients or this population. Do you all list out the stages to the individual? Like, I could see that going one way, like, of like you're educating them on the timeline and potentially these separate things, but also is it kind of like scary, like saying that there's like these freezing, frozen, thawing? Like, how would you even word that to an individual?
Yeah, I mean, on my part, I don't really necessarily say like freezing, frozen, or thawing. Generally, I kind of just explain to them that perfect examples, lady I had this week, so I initially kind of evaluated her. It would have been probably early September. She came in, she was seen by an ortho, told her that she had some biceps tendinitis, tendinopathy, presented pretty classical. I was thinking some sort of rotator cuff related shoulder pain, something like that, kind of painful arc. Range of motion really wasn't too limited, a little bit of pain with kind of resisted external rotation and things like that. Saw her for a second follow-up. Range of motion improved. We were able to get her to, 165, 170 degrees. Visit 2, presenting with about like 120. She's an attorney, so was busy with work, kind of fell off the schedule for a little bit, had some schedule conflicts. So she showed up last week and super painful. Just kind of had like that drained look on her face. Kind of examined her. Range of motion was at like 80 degrees of flexion, about 0 degrees of external rotation. She went to another ortho who told her that she had a shoulder impingement. And then I kind of told her that, this is my concern, kind of given your age, what you're kind of presenting with from an examination standpoint. My first kind of hunch is that this could be kind of early adhesive capsulitis, kind of explained a little bit what that was. This is what I think we should probably do. So I kind of referred her. She was going to see another ortho because she was just super painful. I said, let's send you to my guy in-house here. This is kind of what I'm thinking. It's going to be helpful to get a second pair of eyes on it and kind of see what he has to say. If that is kind of what we think the diagnosis may be, this is kind of what you can expect. Early on, I think it'd be beneficial if we can get you into the ortho to maybe see what we can get, like an intra-articular injection. You seem to have relatively decent evidence kind of in the short term that can be helpful in terms of managing pain. And then after that, it's going to be a lot of just focus on gradual progression of range of motion. But it's not going to be kind of a quick fix. So that's kind of the way that I framed it to her. I didn't really get into too much detail about the specific stages, but just kind of letting them understand that, early on, high pain presentation, this is kind of what I think is going on. This is what you can kind of expect. I didn't really give her any sort of answer on, I guess, time frame. She kind of had an understanding because she was kind of self-diagnosing on the internet. And she did kind of come across that. She's like, I've heard that this can take, 5 years. And I'm like, yeah, the truth is, it's a diagnosis of exclusion. We don't really understand why it happens. And the time response is going to be variable from person to person. The important thing to know is this is kind of where we go next. And this is the way that we're going to try to manage it.
Sounded great. So you referred her to the orthopedic surgeon in your clinic, is that right?
I did, yeah. So I wanted to see what his thoughts were, but I also kind of had in the back of my mind that she's very painful right now. Would probably just be someone who benefits maybe from an injection if we can get it. And I think that's something that's important, just kind of from the diagnosis side of stuff, is just being aware of maybe what a early onset or an early stage kind of frozen shoulder looks like, because that is an area where there may be some cause for orthopedic intervention, particularly from something like an injection, just to help them with some of that early pain. It's not going to change the time course of the disease at all, from my understanding, but it definitely will help with someone with that very early guarding. And I think my kind of thought process is if we can get, protective guarding and pain under control, it's probably going to help us just from a range of motion standpoint to try and minimize, just loss from general immobilization as early as possible.
Ben posted a question. If symptoms and recovery lasts as long as the evidence says, should our approach be different? Perhaps more of an emphasis on long-term management and maybe more spaced out visits? And that was kind of my question as well, reading through the CPG and the other papers, because it's like, in the end of the day, like they're, as you said, it's just like a lot of them have short-term benefits, but the natural history ends up being about like a year or a year plus. So is it even, besides educating the patient and making sure they're trying to be as active as possible, is it worth it to continue to go to physical therapy for this type of condition?
Yeah, so I think it's a really good question, and my kind of thoughts, and I'd love to hear from everybody else, but I think early on people really benefit from getting an understanding, because especially if it's really early on, it's painful. People are concerned, they don't know what's going on. So early on, maybe just seeing them on a little bit more frequent basis, just kind of letting them understand, this is kind of to be expected. We're going to kind of see this sort of time course right there. It's okay. You're not presenting any different from somebody else. But as that kind of titrates down, I definitely would prefer kind of more of a low frequency model, I think, just because The best evidence we have is it just needs to be kind of consistent progressive motion to whatever is tolerable to the person. Some people may need a little bit more of a push, so you may need to see them more often. But I think if I had my preference, it would probably be less frequent follow-ups, just kind of checking in with them, just seeing where they're at, and gradually progressing their motion. So I think I would be in agreement with the person who posed the question as kind of more of a low frequency model, just because it doesn't seem like we have great ways to kind of address this. And outside of updating here and there and providing a little bit of reassurance, making sure that they're on the right track with stuff, I'm not sure how much else we're really going to do.
When would you go ahead, Kevin Hamilton?
I was just going to jump in here. I thought it was kind of interesting, like even the CPG, well, because once you read through it, you're like, all right, this is going to be a long period of time. We don't have, a lot of like great effects. And I like that the CPG sort of lists it out, like if you apply a treatment or they recover very quickly, like odds are it wasn't frozen shoulder. Like, so I just really like that their exclusion criteria here was like really, really nice. So the bucketed system was really neat. And then one thing I was kind of, as I like read through this, between, primary and secondary frozen shoulder, like there's not really, once it comes down to like the treatments, it all just sort of falls into the same frozen shoulder. And I didn't know if anyone had like run across like if frozen shoulder, like primary or secondary, like presented any differently. Does that make sense?
Yeah, so my understanding is I don't know if the presentation is going to be any different, but I think that with the secondary, there may be something in the history that would lend you to kind of believe that there was either some sort of trauma or mechanism, more so to speak, whereas the primary is going to be more just like, this came out of the blue, like I don't know why, all of a sudden my shoulder just hurts and I'm just losing range of motion. That's kind of the only thing that I would say. I don't know how much it really matters in terms of the management side of stuff. That's kind of what I would say there, but maybe there's just something that was more of an inciting event in the secondary. That's my understanding. Because it doesn't really change management, I don't know how important it really is, but it's just something that maybe differentiates the two.
I would say that somebody that has a rationale for why has less of the psycho component coming in, right? So there's less fear catastrophizing going on because, okay, I had surgery or I fell and messed up my arm and it's tightening up. So this is a consequence of that, so that they can kind of logically walk through that, and then you can present it when it just all of a sudden it's hugely painful. I'm not sleeping at night. What the hell's going on? Is this cancer? Is it this? They're running through all kinds of things. And so there's a whole lot of education and just walking back from the edge that typically has to occur.
Kevin, do you want to go down, is it even worth it, to the interventions? And like we briefly discussed corticosteroids, manipulation, patient ed, and hash those out?
Yeah, we can do that for sure. Where do you want to start here? You want to look at just intra-articular?
Surely.
Yeah, so I mean, those of you guys that are familiar with the CPG kind of have an understanding that we have this grading of evidence, right, where level A seems to be from more of kind of randomized controlled trials, relatively stronger evidence. And if you kind of look at even just the summary of recommendations, you'll see that there's kind of a lot of C's and not a whole lot of strong interventions presenting for adhesive capsulitis. But the one kind of exception to that is sort of early intra-articular injections. I think the one thing to kind of point out there is a difference there from the practitioner side of things. So if someone has had an injection, it's probably important to tease out whether or not that was kind of ultrasound guided, because subacromial is not going to produce the same sort of positive benefits that an intra-articular injection would. So kind of teasing that out, because sometimes these people may have already had injections prior. if it wasn't suspected that it was adhesive capsulitis, it's probably more likely that it was some sort of like subacromial injection as opposed to an intra-articular. So just kind of teasing out whether or not that was ultrasound guided is important. Because if it wasn't, then it probably wasn't an intra-articular injection. And based off of, things that I've been familiar with and come across in the literature, it does seem like in kind of the short to medium term, intra-articular injections do seem to have some sort of benefit, at the very least for just kind of getting pain under control, and helping try to maximize frequency and exposure to range of motion activities. So I think it's something that if you are able to kind of catch someone in the earlier phase, it's probably worth collaborating in an interdisciplinary manner with a physiatrist, an ortho, or somebody who can provide that, because a lot of times these people are in so much pain, especially if they're very acute, that any sort of relief is going to be a win just from a therapeutic alliance standpoint. And I think if we can provide that early on, even though it may not change the course of the disease overall, it's going to provide them some sort of relief and get a little bit of buy-in, maybe make things easier on your end in terms of just an early management.
With the corticosteroid injections on the Kelly et al. Paper in 2009, they were saying, there was a part that I highlighted: frozen shoulder is typically considered an inflammatory process. However, this concept is being challenged. No significant inflammatory cells in the capsular tissue have been identified upon histological exam. And they said, clinically, the idea that frozen shoulder occurs in the absence of inflammation is difficult to accept, especially because corticosteroid injections have been shown to have such a significant positive short-term effect. So that was my first time reading that it's potentially not a strong inflammatory process. But I mean, obviously there could be other reasons why that corticosteroid injection is powerful short-term, right?
Yeah, I think it's probably multiple reasons. I would say that's a little bit of an older paper, and I do kind of wonder, I think more recently it does seem like kind of like synovitis of the rotator interval in the capsule seems to be maybe a little bit more of an important factor kind of at play. So I kind of wonder, I did send you that paper over there. I wonder if that has been kind of updated to the point to where we're thinking more maybe inflammatory mediated. That's kind of my current understanding of things. I don't know if anybody else has anything to add, but that's kind of my understanding is you're getting a little bit of maybe capsular contracture or fibrosis, but it does seem like the inflammatory mediators is maybe the prime driver, especially from just a general nociception and kind of pain presentation. That's my current understanding, and that's why I understand that there is that early sort of positive impact from something like a corticosteroid injected into the capsule.
It is kind of shocking that that's the corticosteroid injection is the only A recommendation in this whole CPG.
Yeah, and the funny thing is too, right? Because if you think about it from let's say like a cuff tendinopathy, that's something that we definitely want to avoid, right? So it's difficult, I think, early on in trying to determine, is this, if you have somebody that it does kind of fit, the demographics, trying to tease out, is this more cuff related stuff? Is this possibly early onset frozen shoulder? I think that's really challenging too, because it's going to change management, right? Because to me, if I feel like I'm dealing with more like a cuff tendinopathy, I'm going to try to stay away from any sort of injection as possible, just because we know that the long-term effects tend to be detrimental to the cuff integrity. But if it's someone that's maybe very early adhesive capsulitis or frozen shoulder, would they benefit? And is there some potential that that's what they need right now? So I think it's challenging from that standpoint. And sometimes you may just treat it like a cuff tendinopathy, kind of like I did, until you see that, oh shit, their external rotation is like 0 degrees. So miss that one. Where do we go next?
With the lady that you saw this week, I know you said you called it adhesive capsulitis. Is that the preferred working name for it? Because I know the other paper you sent me had it as FSCS, and then people call it frozen shoulder. Like, what the fuck should we call it?
Yeah, I think, what is it? It's the Lewis paper, right? That says like stiff shoulder syndrome or something like that, or
Frozen
frozen
shoulder
contracture.
contracture syndrome, yeah.
Yeah.
Because they were like, is there adhesions going on? They were like trying to debunk the capsular adhesions. So like, why call it adhesive capsulitis?
Yeah, I mean, I don't know. I think getting hung up on some of the semantic aspects of that, I think it's important, you know, words matter, and we need to be able to define our terms, but adhesive capsulitis, frozen shoulder, I'm just kind of using whatever, you know, minimizes the need to have extended conversations. If I'm working interdisciplinary, you know, if I go in there and I say to the ortho, you know, this person has a frozen contracture, you know, shoulder or something, whatever you want to call it, right? And he looks at me, he's like, what are you talking about? Like, okay, it's frozen shoulder. So I don't know. I don't know how much it matters, right? I mean, your shoulder's stiff. What are we going to do about it? Do you have any thoughts on that? Do you feel like there's something that would be preferential in terms from like a patient side of things?
Not at all. I have no clue. I mean, frozen, like our professor brought it up last year in one of our classes, and he used frozen shoulder. And I was like, that from a patient perspective, is that potentially kind of scary just terminology? Because they're like, now do they even want to move their frozen shoulder? That's the only thing I could see of like their interpretation, but obviously that goes to the patient education and reframing what to do with it. But I don't have a better term for it.
I could see it going both ways. I could potentially visualize as a patient adhesive capsulitis sounding a lot more scary to me, but like you said, equally some patients may be equally scared with frozen shoulder. So I don't really care in this scenario because I think there's cons to both sides.
Yeah, that's kind of where I'm at. Go ahead.
I don't know. Like my thought process is more or less like not necessarily what we're going to call it, but like how or like when are we going to call it that? I think someone mentioned earlier, like if we haven't fixed or the issues resolved within like 6 to 8 weeks, then it's either a later onset or like a later stage type of deal, or like it truly wasn't frozen shoulder. So like I don't know how long in your experience or you guys' clinical experience do you wait to, I guess, give that diagnosis? Because it is a little bit grim of feeling like, hey, you might be in pain for like a year. Like that would really suck. And I don't know, like how do you guys handle the timing of that and kind of the when aspect of it?
I mean, for me, I think kind of relying on the clinical exam, looking at range of motion loss is probably the biggest thing that I would look to maybe change my initial thought process. Most things, you know, it is presenting very early on, similar to any sort of like tendinopathy or subacromial pain syndrome. So I think for me, if we're starting to see, you know, no decrement or increasing loss of range of motion, and we seem to be responding relatively positively, even for things like a cuff tendinopathy, though, we know it can take 12 plus weeks to get any sort of positive change from a symptom management standpoint. But my guess is, especially if you're seeing someone early on, you will eventually probably reach a point where increasing night pain, you know, range of motion continues to decrease. And at that point, if I'm starting to see consistent loss from session to session in range of motion in the presence of increasing pain, that's probably when I start to maybe think a little bit more about that, especially if they kind of fall within that demographic. So to answer your question, I think it's difficult without having kind of like the person in front of you and, you know, objective data to kind of track and monitor across time in terms of when I would go to making that diagnosis. But I think it comes back to, you know, what's the age, what's the gender, what's the body part, what is their kind of objective measures looking like? Are they responding at all? That's probably where I would go first in terms of maybe rethinking a diagnosis. Do you have anything to add to that, anyone?
Kind of just going back to like how we're going to name it, kind of like what Quinn said, none of those names are ideal or great to a patient. And so at that point in my mind, it's like I could probably use either, but I think the more important thing, and Kevin, you touched on this, is sort of just like the progression of it, like sort of like laying that out for them, so that they have a better understanding of like what's coming down the road. And then as far as like when we start using like the actual term, like diagnosing it, that everything you said sort of just goes back to like the like diagnosis through exclusion, you know, like, okay, you're trying this, okay, that didn't work, okay, we're trying this, you know, and so once it becomes sort of unresponsive, yeah, I guess that's when you start using it, or like introducing the idea that it might be something that they're looking at more long term.
Yeah, exactly. I mean, like we said, it's kind of like that clinical diagnosis, right? And even with pursuing imaging, making sure that there's not highly advanced osteoarthritis in the shoulder or something like that too. Like generally, we're kind of ticking off all these boxes to where, okay, it doesn't seem like it's glenohumeral arthritis. There doesn't seem to be, a massive cuff tear or something like that. We're continuing to have increasing amounts of pain. They're losing range of motion. That's it's just kind of like that gradual process of not responding really to conservative treatment at this time. We're not really doing anything that would be suggesting that we're missing the dose considerably to where they're constantly flaring them up or something like that. It's just gradually progressing. Range of motion continues to kind of decrease. So you kind of just, like you mentioned, it's not this, it's not this, it's not this, kind of like, and it's difficult to diagnose, I would say too, I think, because there's a lot of things that may present similarly that would not be a frozen shoulder. So I think it's a challenging condition, I think, not only to treat, because it doesn't seem like we have a great understanding as to the underlying etiology or how to intervene in a positive manner, but it's also difficult to come to a firm conclusion on what we're actually dealing with. So yeah, it seems like it's kind of like a cop-out answer, but I think it is kind of like that diagnosis of exclusion, like you mentioned.
How many conditions do we have that we know 100% of the time that we're diagnosing? I mean, seriously, we're talking about putting names on shit and diagnosing shit, and we really have fucking zero clue on half of it. So I don't understand.
I'm with you. Like, I'm fine with just shoulder pain at this point, right? Is it a biceps tendon? Is it rotator? I don't know. Is it going to change how much I really deal with it? Probably not. So.
Actually, I think maybe it was Ben who mentioned like how we would manage like treatment, and it kind of made me wonder: has anyone like found any papers on like how frozen shoulder gets treated or like diagnosed in other countries that don't have our model of healthcare? Has anyone run into any papers like that?
Kevin, one of the papers you tagged was talking about how UK deals with it. Maybe it was the Jeremy Lewis one.
Yeah.
It didn't seem super different.
Yeah, I think it's relatively consistent. I think that there is similar, like a position statement. I want to say it's Australia has one out there similar to the CPG. For the most part, my understanding is there doesn't seem to be a lot of discrepancy, internationally with regard to how it's actually treated or how the diagnosis is eventually reached.
Dude, it seems like a real shit show. Like, do you think clinicians who get frozen shoulder patients are just like, I mean, when you got the frozen shoulder lady, like, what's going through your head?
So she was, I will say this, I've never seen like an acute like I've seen like some pissed off shoulders before, but like that was something where you could just like see it on the person's face where it's just like so much pain that it's just like draining it out of them, where they just present with you and it's just like this highly defeated look where like, you know, you could tell that the person's like not sleeping at all, you know, stressed, concerned, worried. And like, I honestly don't think I'm like a very like empathetic person, to be honest with you. But like that was one where I'm kind of like, damn, like this person is hurting bad. So I think it's just tough from a clinical standpoint, especially if that's kind of what we suspect, because it's you know that the person has probably a long road ahead of them. So my biggest concern was, for one, I didn't think that her kind of diagnosis of impingement was correct in terms of just supplying her with the information that she would need to kind of provide answers that she probably had, or provide answers to the questions that she had. So my concern with her was, you know, like, this is kind of what I'm thinking. And I think that providing her with that information, maybe even if the diagnosis was wrong, which it doesn't seem like it is, at least maybe provides a little bit more assurance to her, even though it's probably not what she wants to hear. But then my concern was, okay, what can I do next to try to provide some sort of assistance or relief to her? And that's kind of why branching out, seeing if we can get an injection or something like that, just to provide any sort of relief through that there. But we talked about kind of like low frequency versus high frequency approach with these patients through there. So in terms of dealing with a frozen shoulder, I feel like it's just someone that it's almost like, I don't think self-limiting is probably the right word to use, because it does seem like if we don't intervene, it's unlikely that the motion will actually return in the shoulder. But it's one of those conditions where it's like, all right, well, we know not a whole lot's going to change for the next 9 months or whatever it is. So it's just kind of being consistent and following through with rehabilitation. So maybe boring would be the one to think about through there, but certainly not early on, I would say.
Do you have any idea why there's a female demographic that's at a higher probability of getting it? And also, I think, what was it? The age group, obviously, I think 40 to 60 was like the kind of average.
Yeah, that's a good question. I don't know. And I think there's been some papers, I believe, I was just kind of looking quickly before hopping on this week, to where it may not be as much of like a preference in terms of the female gender as there once maybe thought. I think there was a couple papers that came out to where it was like, well, maybe it's not always more common in the female presentation. But I don't know. I mean, I think when we're thinking about just age in general, it does seem like kind of like middle age is where a lot of these sort of general health problems seem to start to manifest and have negative consequences, right? Whether we're talking about, diabetes or something like that, specifically type 2. It's a good question, though. I don't know why it would be necessarily within that age group. Does anybody else have any thoughts as to why it does seem like it always presents kind of middle age?
I have no papers to support it, but just the endogenous changes that are occurring hormonally, and a lot of other kind of things are just changing rapidly oftentimes during that time. We have andropause and menopause and things like that are going on for a lot of these. And so there's a shift in soft tissue. There's some of these other kind of things just from some of those changes. And so it can possibly be a rationale for why we would see things at that time frame.
Yeah, that makes a lot of sense to me, I think.
Do you all have any idea why it's primarily in the shoulder?
So I've heard like competing theories on this. The one that kind of makes sense to me is the fact that the shoulder is a less congruent joint, and there also seems to be like, it's a huge capsule in terms of just the overall size, like from an anatomical standpoint. That's one that I've heard, but I think, who knows why exactly. That's kind of one that I thought was kind of interesting, just the relative, size of the capsule and the incongruency of the joint. I've also heard things where I think it may present in the hip as well, but outside of that, I don't think there's any other joint where we get the same sort of like presentation. And as to why it's the shoulder, I think is anybody's guess. I don't know.
I know Jared Hall gave a adhesive capsulitis talk on Clinical Athlete, and he said there's a little bit of adhesive capsulitis that can happen in the hip. And his hypothesis was like, there's normally more movement and ambulation going on in just lower extremity in general, and you can maybe be more prone to just like under use of the shoulder. Maybe, I don't know. That was his guess, but he was like, I don't have an idea.
I think the other thing that's interesting about the shoulder is, and this may be wrong, but I think, doesn't the cuff actually kind of blend into the capsule itself, where there's kind of like this continuous sort of interface? So maybe something there, which in terms of like the histology of it, to where there's like this gradual transition of like, skeletal muscle into more ligamentous capsule. So there's a few things that are kind of unique about like the shoulder and the shoulder capsule in general that maybe would be a reason why. So that's just something to kind of think about too.
Yeah, and then in the chat, Bert said, could it be because of less weight bearing in general in comparison to other joints? And I think also Jared Hall was talking about like that with the, just like you don't have an option to not walk or use that leg. Yeah, I don't really know. Because then it's just hip pain, right? Like we don't have like a frozen hip, I feel like once it gets, well, and I think like with the pelvis and hip region, low back, SI joint, like all those areas, it just seemed like there's so much of like an overlap of like causes for where you're feeling pain and stuff like that, or so many like reasons, sort of like proposed reasons for why you might be feeling pain in different regions. But like, I lost where I was going with this. You're just gonna have to like keep walking on it, right? Like it's not an option. Whereas like you can use one arm more than the other.
Yeah, and then I think what they talked about with like people who've gotten in accidents or it's been traumatic, and then you have to immobilize the shoulder. That's another reason why you could have it. And then how would you differentiate it from like, say someone has some level of like tonicity or they're spastic, like are we calling that also like, could someone who have neurological deficits have frozen shoulder, or would that be purely like a completely different classification because now it's like a tone related problem?
Shrug emoji, dude. I don't know. I think, yeah, no idea. I'm not sure where to go with that one.
So I have a question. I know that we really can't change much of how these things progress, but I mean, would being more aggressive with a condition like this be more beneficial? I know we talk a lot about not letting pain kind of be a driver for reducing too much load or too much function, and that if we can try and get people to have a better grasp of what their pain actually means and know that, just because you have pain doesn't mean that you can't actually do certain things. Like, would it be more beneficial to try and be more aggressive with loading and getting them to maintain some of those things instead of just taking a passive approach? Because I feel like with a lot of things around pain and seeing some dysfunction, that, we try and promote more activity instead of just stretching and, modalities and things like that.
Yeah, I mean, I think so. this is something where I think, I'm obviously a very young and green clinician, but it's definitely an area where it's been a learning experience, especially kind of flaring people up. Because I have definitely kind of taken that approach to where, like, we need to be more aggressive with some of these things. And especially if we're dealing like specifically with a topic of like an acute, or an early frozen shoulder, like the amount of pain and discomfort that someone is in is pretty remarkable. So especially early on, like if we're going very aggressive to the point to where, we're trying to see changes within session, that may be great. But if it flares them up to the point to where, then, the next 2 days in between where they're not moving the shoulder at all, how much benefit was it really to kind of crank and try to be real aggressive within session there if they're not moving the shoulder for the next 2 days, right? So I think that's where kind of the skill comes in being a clinician and kind of determining, where are the boundaries where we can push, where do we need to kind of pull back. And I think a lot of it comes down to just kind of reading, the person in front of you. There are some people where they're generally able to tolerate more, and then there's others where they have a very different sort of response, and you can't. And I think that's something to where, even just in my short time kind of practicing as a clinician, you kind of get a read for some people as like, all right, this is somebody that I can maybe push a little bit more. This is someone where I can't really put my finger on it, but there's something about their personality to where they just don't seem like they're going to respond well to a little bit more of aggressive approach. So it's just kind of walking that line and finding that balance. So I think to answer your question, probably as aggressive as necessary, but no more, and just kind of weighing kind of the pros and the cons of, okay, if we're really pushing in session, but it leads to, them being flared up and not utilizing the shoulder at all, was that really worth it to, because it's kind of like a 2 steps forward, 2 steps back type of thing. So it's something that it's difficult to give a strong answer to, but that's kind of where my mind goes, is aggressive as we can be within their tolerance, provided that they're not, self-immobilizing in the days afterwards, is kind of the way that I would approach it.
Jared Hall sent over a paper on the it was like, I think only 5 participant study, but they did the like manipulation under anesthesia, and they were looking at like, does muscle guarding play a role? And their hypothesis was like muscle guarding may have a stronger contributor than just like pure capsular contracture. So if that is potentially true, then like being aggressive may just create even more and more guarding. So you may be working backwards. And then Ben said,
especially early on, right?
Yeah, exactly. Ben said in the chat, any ideas why the CPG had no comment on strengthening of any sort? Probably because there's no evidence behind it or studies supporting it. That's my guess. Yeah,
that's my suggestion, or my understanding, is just not enough evidence to make or provide a claim. And that's the thing too, like if you look at like the literature with regard to like frozen shoulder, it's all like modalities and stretching and joint mobilizations and things like that. I think just doing some general strengthening and kind of longer eccentric contractions is kind of the way that I've kind of utilized it, just from a treatment perspective. So like we said, the evidence is kind of shit across the board. So if you're getting range of motion gains and you're controlling pain levels, whatever you're doing, keep rolling with it, because it doesn't seem like there's anything that you're really missing in terms of an intervention standpoint.
Would you recommend, with like that female that you had or any other potential individual with this, would there be a strong suggestion for just increased or maintained activity in other limbs, or just in general? And like, is there any research showing that like continued like just walking, aerobic exercise, lower extremity strengthening has any significant outcome?
I don't know if there's anything specific to my knowledge, but when I think about like, if we say that there is some element of systemic inflammatory process that's going on, especially if we're dealing with people that have metabolic issues, right? we know that exercise is good in combating some of those things. So my advice to her was, just like anybody else, rehabilitation is, I want the person to maintain as much of a training effect as possible and things that are important to them within the constraints of their condition, whether that's shoulder pain or whatever it may be. So yeah, my advice to her was, I know you're in pain right now, but use your Peloton, do whatever you got to do something, just try and remain as active as possible. Even walking, right? Just think about arm swing during gait, anything like that, especially if somebody have their super stiff shoulder where they have like 30 degrees of flexion or something like that. That's any sort of motion that they can continually expose themselves to at a high frequency basis. I'd say go for it, right? So that's kind of my advice, is remain as active as possible. Let your symptoms be your guide.
Besides the timeline, like let's say you have a tendinopathy or subacromial impingement syndrome or frozen shoulder, does like your intervention change at all besides like their limitations in range and pain levels?
In terms of like treating like a cuff tendinopathy versus adhesive capsulitis?
Mm-hmm.
Yeah, I think the acuity of, I guess it depends on kind of the stage, right? So definitely someone who's very early on, where highly pain dominated, they're likely not going to be able to tolerate kind of some of like things that I would say would be more go-tos in terms of like treating like a tendinopathy, whether that's longer times under tensions, kind of like slow loading, trying to provide high amount of strain through the tendon. So I think early on, yeah, it's much more of, I would say, not a passive approach, but probably more just motion focused in general for something like a frozen shoulder, as opposed to controlled loading and probably strengthening. But I think ultimately people kind of always end up in sort of the same place. Just as kind of what I've started to notice. But I just think it's kind of the starting point would be different. Yeah.
So I know we've talked a little bit about kind of like an integrative approach. With people like this and other chronic conditions, I know that like the psychological aspect can play a huge role in a lot of these things. Is this something where like counseling or other therapeutic approaches may be important to kind of help with these things? Because physically we know we're not changing a whole lot. So is this more of like, we really need to address psychological things or like social norms and things like that? Because I mean, essentially we're taking them out of everything that they're used to because physically they can't do it, at least initially. So like how much of a contributor is that, and how much emphasis would we put into it? Or again, would it just be one of those, it depends on who's in front of us and who we're working with?
Yeah, I think kind of my default answer is probably like the latter part, like you mentioned there. It's going to be kind of highly specific to the individual. But I think getting professional, I struggle with this sometimes because there's also sort of the counterpoint of, over medicalization. And I think that's something to consider as well. So I don't know. I think it's difficult to determine whether or not, this person is, presenting with things to where like I feel like they need to go and see some sort of, whether that's a rehab psychologist or whatever have you. I think that's a difficult discussion to have, for one. And I also feel like it can be maybe a little bit of a sensitive discussion, especially coming from my end, where like, you're presenting like this, I think you should really go see someone. So I don't have a good answer for you there. Probably the better relationship that you have with the patient is probably the best sort of indicator as to whether or not they would be, one, receptive to that information, and if you're even kind of reading them correctly. So I think it's always important to consider those things, but I don't have a good sort of heuristic to guide the decision as to definitely if this person is presenting like this, they should go see somebody, because I just think it's challenging to really kind of pin that down.
Well, and there's also the fact that, I mean, we really should be leading that with questions. right? I mean, it really is. How are you dealing with this? How is your family dealing with this? Do you have good support? Do you have that? We're asking those broader questions because it's the whole human in these kind of conditions, their families and other things that are experiencing this as well with them, right? And so having that broader conversation, they have support, they have all those kind of things. They're probably fairly good. I mean, in his case, highly competent, educated attorney probably has other resources, but there are people that aren't going to have those resources that you may have to become that resource for, but we should be asking that, not necessarily telling that to those individuals.
What about the paper, the Lewis paper? You briefly mentioned this, Kevin. When would you look at imaging just to rule out some like avascular necrosis, osteosarcoma, potential fracture? Like, when does that come to your mind?
So I think, again, when we're talking about, is this truly a frozen shoulder? Usually they'll probably have some sort of imaging done before you kind of come to that conclusion. One, just to make sure that there's not advanced glenohumeral arthritis or something like that. So my kind of opinion with that is, especially for something like an x-ray, which is cheap, you know, radiation exposure is very low. I think it's probably wise to get some sort of imaging, even if it is just an x-ray, before you kind of start to think that, oh, this is probably frozen shoulder, because you don't know, right? It could be just advanced OA, or like you said, like a bony tumor or something like that. So in my mind, if I'm seeing someone where, okay, maybe this is kind of looking like, you know, an acute frozen or an early frozen shoulder, do they have any sort of imaging done? If not, x-ray is a very simple kind of first line intervention to go to just make sure that there's not something else at play there. So I think that in order to come to the diagnosis, like we talked about, because it is one of kind of exclusion, you need to have some sort of imaging, even if it is just an x-ray prior, before I would say that you can be somewhat confident that it is a frozen shoulder, just because who knows, could be glenohumeral arthritis or something like that. So I'd probably say early on, I would go to that first, just because it helps me know what's not going on.
What about with the CPG? I mean, you've got relatively low level evidence for interventions of modalities, joint mobilization, manipulation. Like, where's the argument to be made for a PT to say, like, well, I'm just going to throw everything at it and see what sticks, and like, I'm going to try it all, and like, they don't really know what's helping or what's not. But where do you draw the line between like, this is what I'm willing to do for this patient, or being open to be like, well, as you said early on, they could be in a ton of pain, but then you recommended potentially a corticosteroid. But like, how do we differentiate between what's solid care and what's just excess for this type of population?
Yeah, I mean, that's a good question, right? So I think there's been some evidence to show that, you know, manual therapies had no added benefit versus just exercise alone. And I think it always kind of comes back to this circular question of, you know, risk versus benefit. Is there a potential where you're creating this sort of dependency to where this person feels like they have to have someone actively, you know, passively moving their shoulder or something like that? So it all comes down to the framing in my mind. And I think I'm just hard pressed, especially with something like this, where we know that kind of the course of it is really going to be relatively unchanged, kind of no matter what we do, as long as we're providing some of those minimum things, which in my mind would be, you know, exercise and active motion. So I guess it really, to me, I'm just hesitant to prescribe much more than that, just because I don't see the benefit to it. And in my mind, it just costs them dollars and maybe is a risk to the self-efficacy of themselves, or the locus of control. So I think especially where you have someone where it is such a kind of I don't know if traumatic's the right word, but it's an alarming kind of condition, right? To where it's highly painful, you're losing range of motion very quickly. I think the more that I can kind of put them in the driver's seat, probably the better, just because they're probably coming from a place where they feel like they don't have much control overall, especially if it is kind of more primary, where it just came on all of a sudden. My mind, or I guess my bias would be to trying to minimize passive as much as possible. Maybe early on I could make a better case for it, but certainly kind of in the later stages, I'm trying to stay hands off as much as possible. Does that answer your question? I feel like I just kind of rambled along a little bit.
That was great. I could feel Chad Cook, who fucking went hard a few weeks ago, of like, there's no evidence for like clinician dependent or patient dependency with manual. So I could see that argument of like, you can't say that it's gradient dependency, but also, as you said, like, is it necessary and does it change outcomes is, I think, a better argument than like, it could make them dependent.
And kind of just to add to the shit show that is frozen shoulder, we have a debate in our class coming up, and it's just not the greatest. It literally, the positions were already determined for us. One side is manual therapy speeds the recovery from frozen shoulder, and then the other side is just exercise speeds the recovery for frozen shoulder. And it's just like, everything
You have to
we
say
know.
which side you're on.
Oh, I'm on the exercise side, thankfully.
But from what we know, they both do, or they both don't.
Yeah.
Paul, you're exactly right.
So you can't be wrong in your argument, right? I mean,
It's not great, let me tell you. But I kind of like my biggest takeaway from this, because I'm still a second-year student with Chris. So all these patients I see are just hypothetical in my head. Like my biggest takeaway is, so like if it's a primary frozen shoulder, and kind of like what Kevin was saying, like at the beginning side of frozen shoulder, like you might have the greatest effect because you're sort of like laying out what to expect, and you can also sort of like talk them back off that cliff, or any fears that they might be having. And honestly, that seems like, and sure, some of that goes into like pain education as well, maybe, but all of that seems like the most important part of this whole process, since it's going to be so long, rather than like doing exercise, like stretching the crap out of their shoulder, or like trying to do manual therapy. Because okay, if we can't really change like that timeline, it's like changing their experience throughout that timeline is probably where I'd be aiming. I don't know.
that's part of it. I would say though that there's strength in helping them understand where, like, okay, I'm moving you through, and when you get to that where you kind of feel some light resistance, okay, that's kind of where you want to be. See, when I go here, oh, that really hurts. We don't always want to be there, right? Giving them some context and that education of how and when and where, how much to push, how long that expected, we gave a minimal effective dose and we expect a little irritation because it's already an irritated tissue, but it's going to come back. All those kind of things are great talking points that we should be having over multiple contexts early, I think, to set those expectations and give them those guide points, and then they can go off. But if we think that we just hand something out or talk to them once and everything's hunky-dory, that's not the real world, right? That's not what these people actually need. And so there's what the literature says and what's actually happening, and somewhere in the middle is probably closer to where we need to be. And things, because there are still human interactions. People do still enjoy wanting to see somebody, have an interaction with somebody and learn that, and there's specifics that can be learned within that interaction.
Cool.
Yeah,
No, that.
Go ahead,
go
Jeff.
for it. Oh,
Yeah, I was gonna say. All right, go.
Okay, I was just gonna. We're like a mirror, except not. Anyway, so yeah, I mean that's super helpful to sort of like help them explore that uncomfortable territory and have them get a little more familiar with that, and maybe through that guiding process, like the pain and discomfort is less threatening. I like that way you sort of like laid that out for a patient.
I have a question. What the fuck is with these pendulum exercises? Like that was like the first thing that was taught to us, and I've seen it. Like, is there anything magical about it, or is it just like an unweighted, just shift the hips, move the shoulder?
Well, novelty is powerful, right? How often do you just kind of just dangle your arm right there unless you've had a post? There was actually just a recent paper, I think, that came out looking at, there was actually like pretty significant like cuff activity, I think, with an EMG, even with like a pendulum or something like that. So like the whole idea that you're not getting any sort of activity through the cuff during like a Codman or a pendulum doesn't seem to necessarily stand up. But I think to me, it's just like, just showing the person, like, it's just an entry point to movement, right? So like you have somebody that's just terrified to move their shoulder. Okay, well, where can we start? You know, and maybe that's where you go first, right? Or maybe it's just some like body on arm, shoulder flexion or something like that. It's all just kind of grading their exposure to getting a highly painful and irritated joint moving again. So if there's any magic to it, it's probably that. It's a low threatening position, a little bit of traction through the shoulder, maybe feels kind of good. That's what I would say.
Yeah, but have you ever gotten anybody to do a pendulum, true pendulum?
No, I can't even
they're
do
always
it. I can't
active.
even do it
Nobody
either.
can.
Like,
Especially on a stiff, sore shoulder. Nobody can do it.
yeah, I can't sync it up, man. My hips and I just can't do it, you know?
Too white. Just can't do it. Does anyone have any other questions? I feel like we're at this roadblock of like nihilistic. There's nothing magical about interventions for frozen shoulder.
Well, again, for most conditions, you treat what you see. It's context specific in front of you, right? And we're the guidepost. This is just a long guidepost that we're providing, right? So we need some early intervention to set up truly what the expectations are and stuff. And really, even to Kevin's point, kind of figure it out sometimes, right? I mean, because this is, okay, I started treating this way and now that's not working. But it also speaks strongly to the test, retest, both in between sessions, but sometimes even during sessions. So do I know that anything that we're doing is having any specific effect, right? Because many of these patients will start to stretch hard at home, harder than what you even wanted, and they start to regress because of pain. The guarding and all that other kind of stuff starts to show up, right? So again, that's where our intervention of, okay, so let's go over what you were doing. How hard were you pushing? What were you doing? That walking them through those decision trees and helping give those guidance points. So oftentimes we think we have to intervene, right? But education is intervention. That's skill, right? Helping somebody understand and deal with. And to Kevin Hamilton's point, can't say Kevin, just to his point, it really is giving them some of that context and giving them some of that framework for this long-term thing. So I've been in practice for 25 years. I've been the guy that's cranked on these things really hard. I've been the guy that's like, okay, we're just going to move. I'll see you in a month and we're going to see what's happening. Different people respond differently within this context, right? So we do need to know where that is and who they are and see them with somewhat of a frequency so that we know. And some of these people, once it gets turned on, as the literature shows, if they don't work towards those end ranges, they don't regain them, right? So our idea is to find out when we need to be intervening. And sometimes that means bringing them in. And now we really can do what we want to do intervening wise. Right now I can start gaining some more of that motion. I can really help them see that progression, but determining when that's going to be, you do not know with each individual person. There's no literature that's going to say this is right. So you just have to always be kind of learning and reassessing as you're going. And so that's why I argue that a diagnosis doesn't mean shit, because you're always reassessing and always replanning and always responding to the stimulus given back from the patient from the stimulus that you get.
Yeah, I think really well said. Paul's bringing the wisdoms this morning.
I do have a question in regards to, I know we said that since this is a prolonged time frame and we may not necessarily want to see them as often and try and drag things out a little bit in space visits, how open do you keep like that communication line between you and the patient? I know I've heard some people talk about that where they have like open access to constant communication with their provider. Is that something that you guys who are practicing where you do allow them to like reach out to you throughout this process, or do you try and like maintain some distance from your patients and not have that continuous like open line of communication outside of the office where they can reach out and get a hold of you? Like, how do you draw that line, or is it kind of already laid out before you see patients?
Guess it depends on how cynical you are. So this gets into an interesting discussion just on like uncompensated work, right? Especially if you're on like a salary or something like this, like how much time are you willing to dedicate and devote outside of kind of your normal work day to patient care, whether that's answering inbox messages or things like that. I think that's something that you kind of need to determine for yourself and kind of set boundaries, because that's the biggest thing, is like just kind of set boundaries with your patients. Let them know that, look, I'm available from this time to this time. I'm happy to answer, if you send me an email or something like that within this time frame, I will get back to you. I think you can kind of go about it wrongly in both directions. One, making yourself unavailable completely other than, their time that they're seeing you in clinic or whatever have you, I don't think is the right way to go about it. But I also think that if you're constantly available and you're kind of setting the precedent that, every time that they send you a message at, 11 o'clock at night or whatever it is, and you respond to it, it's probably not the best way to go either. So I think just setting some sort of boundaries for yourself that you feel like will not only provide care that you think is beneficial and good for them, but also allow you to be consistent and set some sort of boundaries to where you're not answering, patient emails at 11 o'clock at night to kind of make sure you don't burn yourself out either, is probably the best way to go about it. So probably going to be very individual, but I think setting boundaries and being consistent with that's probably the best way to go about it.
Without a doubt. Some of that may be set by your employer, right? Depends upon what controls you have. But if your employer wants you to do that, I would always strongly encourage you to say, well, then I need Wednesday from 11 to 12, or right after lunch, the 30-minute block in which I'm going to respond to all these emails, right? So you're requiring me to have this open access. I'm also going to require some time to actually do that. That would be the pushback, right? Block me some time. I'll be happy to do that. And I think that's part of good patient care, but it needs to be during my hours, right? And then you can just tell your patient, hey, look, Wednesday afternoons is when I get back to you, right? Because that's the time that I've got blocked. So make sure that you are protecting yourself in that regard, because oftentimes employers will say, yeah, you're going to be access. Well, are you paying my phone bill? Are you going to be doing that? I mean, what else is going to go into that, right? So you should be getting something from that. And it should just be, even if it's just a 30-minute block once or twice a week, if that's going to be a requirement, then you should have that time blocked away to actually serve what they're asking you to do.
Derek, do you or Logan, I know he's on the call, in Chiro school, have they gone over frozen shoulder with y'all? And what's that narrative been?
I haven't heard anything about frozen shoulder in chiropractic school yet. That doesn't mean that we aren't going to talk about it. I heard a little bit more about it when I was going through athletic training. It was a talking point that was brought up. So, I mean, I've never personally seen it. So yeah, I mean, I really have nothing to add there, unfortunately. The only other thought that I had, because I know with COVID and everything, like treating has changed and how we see patients. would this be something that maybe like telehealth would even be more beneficial than having them continue to come to the office, where it could just be a quick, telehealth visit, you see how they're doing, and then you just kind of move on instead of getting them to come all the way to the office to try and navigate those things. I know that we've seen some benefits with telehealth and continuing to kind of have our patients navigate on their own at home instead of relying on us, but I didn't know what your guys' thoughts were with that.
I do a hybrid with some of my patients, even those that are longer term, right? So I'll see them in clinic, do some things, do some education, and then they'll be treated, quote unquote, right, through telemedicine, which is really much more of just the guidepost. Let's talk you through this. Let's see what the exercise looks like. Let's see what that motion looks like. What problems are you having with XYZ? See if we can't fix whatever that is, right? Sometimes, well, every time I use the wand, I do this. Well, are you standing? Yeah. Well, maybe you're activating in the dynamization of the capsule is creating some irritation. Try supine. Let's see what that does. Making various modifications to still keep them moving are things that you can walk through very, very efficiently through a telehealth service, and not have them come in and not feel like, well, I didn't put my hands on, or I didn't do XYZ, and that's what I'm supposed to be doing in an in-person visit. So it helps lower that expectation from the client and from you, right? And so you can just stick with the education and seeing how well you move. But I still think that early on, at least hands-on, to teach some of that feel and some of those other kind of things is important. But after that, yeah, I think that would be a good place where that would serve us well.
Side note, did you all see that JOSPT editorial about telehealth and its recommendations? It's really bad. It's like, make sure there's no rugs or dogs in the room so you don't trip. Like, it was probably one of the worst commentaries I've ever read, just because it was like, no shit Sherlock, but I highly recommend it. I'm gonna find it and link it because it's pretty comical.
Yeah, but if you've ever done telehealth, like at any real frequency, it's a shit show at times.
Oh God, it's terrible.
Yeah, it's a shit show at times. The technical issues, it just, you got a camera angle and they're like, okay, I'm exercising now. You're like, what the hell is that? I mean.
So when I was working at Hopkins, I had this person was a post-op, I think he was a labrum or something like that. But so his phone fell over, and basically it was just like I was just staring at a ceiling fan for like 30 minutes. And I was like, no, I can't see you. Like, he couldn't hear me. I was like, no, I can't see it. It's like just 30 minutes of a ceiling fan. I'm like, all right, well, I got to go to my next appointment. So doesn't seem like you're in any more pain or anything after that. So I'll see you at the next one.
It can be wild. It really, really is weird. And you'll see things in people's houses, and people don't they're inviting you into their house, right? So the wife walks by in her bra, you've got all this other kind of shit, and you're just like, what the hell? Do you not have, but that's just the way that they live, right? I mean, it's wild.
Jeez. All right. Does anyone have any final questions? If not, we can wrap it up. Perfect. Thanks, Kevin. I know this was a hard subject to dive into.
No, man, this was fun. I appreciate you having me on. I always enjoy these. So, yeah, hopefully some benefit came out of it. I felt like it was a good discussion regardless.
Yeah, no, it was great. I'm curious, the debate groups, we have them on Tuesday. There's like, I think, 5 people on each side. I'm curious how both sides are going to structure it. I have no clue. But yeah, this was dope. I recorded it, so I'm going to post this little drive.
I want to see the video of the debate. That's what I want to see.
Dude, okay,
All
so
right.
last week's debate.
Don't tell the other side, but I'm just going to go straight ad hominem the entire time. Just like, forget the topic, go after the people, and see where that takes me. I don't know.
Last week, my group, we had I was on the exercise side for shoulder tendinopathy, and the other manual group. Manual won by like 15 people because it was like a poll. But you only get like 4 minutes to rebuttal, and then you can't, once the other side rebuttals, you can't like ask the other side questions. So you're set up for failure, and it's a popularity contest. And Kevin and I are easily the most hated students in our class. So
there's no cross-examination?
no, it's fucking awful.
How is that a debate?
It's a memorized or just read this statement conversation. It's not great.
Like
anyways.
we have a rebuttal section, but
4 minutes.
it's not great. Yeah.
Yeah, in 4 minutes you summarize their points for them, and then it's off to the
Yeah.
But this is what you were saying. You this. Yeah, there's your time. Oh, I just made your argument again.
Yeah, it's not ideal. But anyways, thanks everyone for joining the party. Enjoy the rest of your Saturday. Happy Halloween. Get stoked. Kevin, what's your favorite Halloween candy before we leave?
My favorite Halloween candy?
Yeah.
It's definitely not candy corn.
Good call.
Disgusting. Sorry for any candy corn lovers out there.
Right.
I'm gonna go Reese's, man. A little bit of peanut butter, a little bit of chocolate. Can't go wrong.
You cannot go wrong. Dope. I like that. All right. That was a great ending. Thanks again, everyone, for showing up. Have a great weekend, and I'll see you later.